know that folks are going to be trickling in here as we get going, but I'm going to just get the introductory slides going. I want to welcome everybody. I see some familiar names in the attendee list. I'm really happy to have everybody, both attendings and fellows. We have a great topic tonight that we're going to be presenting on global sagittal balance and segmental angular change in the degenerative setting. Said in a much more colloquial way, what we really want to do is talk about how we change sagittal alignment in smaller degenerative cases, what the rationale for that is, and what the best way to do it. So we're going to have a little debate style webinar tonight, but this is me. I'm Matt Coleman from Rush. I'm really, really honored and lucky to be joined by two of our ex-fellows who are now forging academic careers, molding lives. Sepan Gandhi from Beth Israel Harvard and Evan Shia from HSS. So just a little bit about the webinar series. We've got a couple great tumor webinars coming up from Dan Shuba's group and also Jeff Mullen's group. We also have a full spread of webinars coming up throughout the rest of the year. And generally we have them on Tuesday or Wednesday around 8 p.m. We have some great topics coming up, so I encourage everybody to tune in. AO is a nonprofit. We're about education. This content's not for marketing purposes. And then just a little Zoom etiquette. The one thing about this webinar is we don't have that many participants, so I really hope that people will chime in. You're not gonna be able to speak over the speaker, but if you could use the Q&A box, the people that aren't talking, the panelists that aren't talking will answer questions and comment, or even call out questions live. Just don't use the chat box. That's just for the panelists. So the learning objectives, we want people to understand the rationale for treating degenerative pathology in more of a deformity mindset. We want to understand the difference between traditional posterior versus anterior column approaches to do that. And then I'm going to have a few slides at the end about future directions. So again, thank you so much for joining us. I'm going to kind of get into my deck here. So I don't have any relevant disclosures for this talk, although I am a committee member and receive fellowship funding from AO North America. I want to start, as we usually do, with a case. This is a simple case. You know, most of the talks I try to give, I try to thump my chest and put up a complicated case. But I think this topic is really it's an everyman topic. It's an every surgery topic. It's meant to be a new sort of a more sophisticated way to think about what we classically have considered simple problems. So this is a 62-year-old female, has bilateral L5 radiculopathy and back pain. She also feels like she can't stand up straight. Decreased sensation, no motor changes. So here's her AP and lateral x-rays. You can see it looks like a degenerative spondy at L4-5, grade 2 probably. Her flexion extension radiographs don't show too much dynamism. We have this is a little bit of a foreshadowing for another webinar coming up on degenerative spondylolisthesis, but you can see, without getting too much into the theory of degen spondies, this is not a very dynamic problem. Although it's a grade 2, it doesn't move much on flexion extension. The MRI, same thing. Comparing the standing radiographs to the MRI, doesn't move much, but there is the expected degree of central and lateral recess stenosis typical of degen spondies. So how we address this, you know, it could be a 10-second conversation. Every fellow out there is pretty well trained to know kind of what to do. Some of you have gotten a little more sophisticated and have a new or alternative way to do it. But the way we think about these is the sort of the topic of our webinar. And, you know, when you think about the goals and the options, the traditionalist, you know, this patient's going to do well if you decompress the nerves, if you obtain stability. And you could argue, you know, this isn't that unstable. It's not a dynamic spondy, but if you look there, you know, even in stable spondies, there's still an element of instability. Certainly after decompression, that instability can increase. So obtaining stability is a real goal. But, you know, I would encourage you to start thinking about these straightforward spondies in a bit of a more sophisticated way. So So what are the risk factors for progression of this spondy? You know, what's the pelvic incidence? What is the overall lumbar lordosis? Is the patient compensating other deformity? Do they have a very tall disc that has the capacity to move and degenerate further over time? Do they have other pathologies surrounding the area? What's their BMI? What's their comorbidities? What's their frailty? So all those things, I think, as we start to consider how to treat this patient are important to think about. But it gets, as you learn more and more spine surgery techniques, it gets confusing and overwhelming concerning what exactly to do for this patient. I mean, I'm not going to poll the audience, but there's a lot of different approaches to this problem. And so part of this talk isn't really supposed to be all the different nuanced ways of how to treat degen spondy. It's really, what do the different ways of treatment actually do for you in terms of alignment? So obviously deformity problems need deformity surgery. You have big thoracolumbar adult degen scoliosis. Obviously, there is a role for limited or small surgery, but real deformity problems, if that's the patient's clinical problem, need bigger surgery. And most degenerative problems do pretty well with just very straightforward, simple surgery without consideration of alignment and pelvic incidence and all those things. And they probably do well, and many of them might do well for some amount of time. But my thesis to you is that they don't all do well forever when you don't address their underlying deformity. So you can get patients with a lot of compensation effects, retroversion of the pelvis, hypokyphosis of the thoracic spine. And if you don't recognize that and recognize their actual underlying deformity, those patients are sort of high risk for problems in the future. In other words, they're begging for you to use a deformity mindset in planning your reconstruction, even if the case is a one-level case. So, sagittal imbalance, when does it happen for degenerative disease, and how does it present? Well, it's actually kind of interesting. The patients come in with a degen spondy at one level, and they may have actually a relatively fixed deformity in other areas of the spine. Even though you're not seeing spondylolisthesis, you're seeing an overall flat back or other types of deformity that's pretty rigid. You can also, simply just have instability related deformity. Just because they have one or two levels of spondy, they're actually sagittally off. And then, of course, patients may have no deformity, and they just may look deformed because of the stenosis and the kyphosis that creates when they stand. So you have to get these issues right and understand what the underlying problem is. And a lot of the ways we do that include, flexion extension radiographs, bolstered films, comparing the MRI supine to the standing X-ray. You think harder about those topics. Well, why does this segmental correction, why does the overall sagittal balance matter in degenerative surgery? Isn't that a boring thing that they talk about at the SRS and we don't really need to pay attention to in our ASC where we're running 2 rooms and doing 8 cases a day? Well, I would submit to you to slow down and consider this issue. And the reason is the data supports it. So there's multiple papers that show the ASD risk is much higher if you don't get sagittal balance correct. So leaving the patient with an SVA over 5, low post-op lumbar lordosis, and a PILL mismatch led to a higher rate. It was an independent predictors of ASD at the next segment, a clinical ASD that required surgery. And what about this paper, which shows PILL mismatch over 10 degrees has actually 10 times the rate of ASD revision in short segment lumbar spinal fusion? Pretty powerful statement there. Also, patients, do they do better with their PROs if you get the degenerative case correct with an overall deformity alignment? Well, this paper actually said they didn't see an improvement in PROs if you corrected the global sagittal balance or lumbar lordosis, but they admitted that there was only really 2 studies included, and they're both underpowered. So, this is an area that probably needs more study for all of you budding researchers. And then just one other paper, sagittal alignment sagittal malalignment in this series, in contradistinction to the previous one, showed a significant postoperative back pain on VAS scores when you left the patient with a high sacral slope and residual pelvic tilt. So what else? So sometimes you can think a case is just a simple degenerative case, but what you're really operating on is the tip of an iceberg. It's about to be a big deformity. So this happens in a couple settings. I do a lot of short segment fusions in degen scoli rather than jumping to T10 pelvis every time. I try to do as many 3 to 5s and 2 to 5s or 4 to 1s as I can. And if you don't get the alignment correct in that short segment, you are going to have an acceleration of the overall deformity and not do your patient any favor. It's going to require a bigger revision later. And furthermore, you may just be seeing a degenerative scoli that's happening early. And if you don't establish the proper base and the proper initial correction, it can become a bigger problem later. Certainly patients with high pelvic incidence or patients with even a low pelvic incidence and a low thoracic kyphosis could be at risk for this. So the point is, if you don't pay attention to pelvic and sagittal parameters, I know there's a fatigue with these parameters, but I do think they're very important. Your best intentions can lead to big problems later. You can be creating bigger deformity. So before I turn it over to the panel, I'm just gonna conclude by asking the question, are we not, in today's era, are we not opportunistic enough in treating our lumbar degenerative problems? So when we do short segment, quote unquote, easy fusions, are we missing an opportunity to actually help these patients and help eliminate future problems, or help, at least if the future problem is a big one and it's inevitable and you're really seeing the tip of an iceberg, are we missing an opportunity to make their future trajectory easier? So I think we could all agree on, after this scintillating 10-minute introductory talk of mine, that we should probably take a broader global look at these smaller degenerative cases and try to be more sophisticated with the way we treat them. I also will hypothesize that, you know, not every case needs as much lordosis as you can possibly build in, but generally building in lordosis is going to result in a more favorable environment than not building in lordosis or creating kyphosis. And what I want to do now is turn it over to my panelists, who I'm very grateful to have tonight. And I want to have a little bit of a debate using this case that I presented, but also just in general. What's the best way to build lordosis for patients and really dial in their segmental angle if you're going to operate on a level, in order so that you can really be as sophisticated as you can in adjusting global parameters? Before I turn it over to Sepan, I had some tongue-in-cheek examples that, you know, some people may throw out there that these techniques are the savior of sagittal imbalance, but I found some really phenomenal examples of how to mess up sagittal balance from some of my partners, of course. And I wanted to show these. So what if maybe you do an anterior column approach and do a bunch of A lifts and X lifts and then perk the back. Doesn't that do a phenomenal job at correcting sagittal balance? Well, not so much in this case. You know, there was just a very modest correction of lumbar lordosis. So the patient's still going to be very, very sagittally imbalanced globally. What about doing some standalone A lifts? Maybe those are strong enough. Well, this is a great case where the spondy actually increased. I think the balance got worse. All the cages subsided, and this patient's in a lot of trouble now as far as their sagittal balance. And what about the expandable T-lift, which is the savior of cantilever and building in lordosis? It's not true. You know, this is technique driven, and you can see even with these beautiful expandable T-lift cages, if they're not entirely used correctly, or, you know, you don't quite assess properly intraoperatively how much lordosis you're building in, you can actually end up kyphosing the spine even with expandable cages. So I'm I'm going to come back to emerging techniques and technologies, but I'm going to turn it over to Sepin, who's going to talk about the posterior approach. And take it away, buddy. Tell us why T-lifts and posterior approaches are the best. And this is also a reminder to please let's use the Q&A while Sepin's presenting. I'll try to do my best to answer questions.
All right, can everybody hear me okay?
Perfect.
All right, great. So so it sounds like Dr. Coleman is saying that all the approaches stink. So I'm going to do my best here to talk about why the posterior approach is the best approach. You know, I definitely agree with Dr. Coleman about trying to pay attention to segmental change and global balance when taking care of degenerative problems. And so my job tonight is to tell you why the posterior approach is the best approach. Let's see here. So the goals, this has been mentioned in some form or fashion before in other webinars, but our goals in spine surgery are first and foremost to minimize complications and then all of these other things. So after minimizing complications, we want to make sure we decompress the nerves well. We pay attention to alignment and global balance, which is the topic of this webinar, and we achieve a solid fusion. And so, you know, I would say that posterior approach is just as good, if not better, at doing all of these goals compared to anterior and lateral approaches. You know, the great thing about posterior approaches is that it's very efficient. It's one approach, one position, one surgeon, and you're really minimizing position changes. With lateral and anterior surgeries, oftentimes you're positioning and repositioning patients, and it increases the amount of time that patients under anesthesia, and sort of less efficient than doing a posterior approach. The other pro is that it minimizes approach-related complications. And of course, you know, some may argue that the risk of infection or bleeding may be a little bit higher, but with anterior, you know, lateral approaches, there's a very real risk of vascular, bowel, or kidney injury. And just because it doesn't happen very often doesn't mean it's not devastating when it does. And I'd also make, you know, not to get very dark about what happens in spine surgery, but I'd also argue that a dense hip or quad weakness after a lateral approach is much more devastating to a patient than a foot drop, and much less treatable than a foot drop is. Also, a lot of times we see that an anterior lateral approach isn't enough, and patients need an anterior posterior approach or a lateral posterior approach. And just because you're making smaller incisions doesn't mean that there isn't more risk. So like if you're doing a lateral and a posterior approach, you're sort of taking on the risk of both approaches. Another pro to a posterior approach is that you have access to multiple levels. So many of the patients that you'll see when you start practice, or if you're in practice, don't have just single level disease. You know, they have multi-level disease. And with the posterior approach, it's much easier to address multi-level disease. With anterior and lateral approaches, much more involved to try and address multi-level disease. And there's a lot more resetting of retractors and manipulating important structures. And so you certainly don't have that versatility that you do with a posterior approach. Additionally, you have the ability to directly access all aspects of the spinal column with a posterior approach. So you can do a direct decompression. You can get to the anterior and middle column, whereas you may not have that ability with anterior or lateral approaches. So, you know, the topic of the webinar is segmental alignment, right? So if we're just comparing what can be done through a disc space, lateral and anterior approaches are really compelling compared to posterior interbody techniques. So if we look at this paper, they found less favorable lordosis and disc height changes in the T-lift group compared to the anterior and lateral groups. But the other thing to take away from this paper is that it's really hard to get lordosis back with just inner body work. So look at how much segmental alignment they're talking about in these groups. In the anterior group, it's 4 degrees. In the lateral group, it's 2 degrees. In the T-lift group, it's less than a degree. So it's really hard to get segmental alignment back with just inner body work. So oftentimes, posterior work is needed to get real change in alignment. In this biomechanical study, the authors needed a 30-degree cage with an anterior column release to get 10 degrees of lordosis through a lateral approach. And to get anything more than that, they needed posterior work to be done. So they needed to do facetectomies and spinous process resections to get more powerful correction. So if you just put a large cage in through an anterior lateral approach without doing any sort of posterior work, you may just be getting more distraction of the disc space rather than any real true lordosis. So if you look at what could be done through a cantilever T-lift or like a well done T-lift, you can get similar levels of correction. So in this paper, you can get 7 to 10 degrees of lordosis with a cantilever T-lift. And here's another study that shows that you can get 7 to 10 degrees of improvement with a T-lift with a well done T-lift. In this study, they did bilateral T-lift. So as a result of that, they're doing bilateral facetectomies, but certainly a good improvement in the segmental alignment. So, you don't just have to do a T-lift or use the disc space. Besides the disc space, posterior approaches have a lot of other options to affect the alignment and create lordosis, particularly in the area of posterior column resection and other osteotomies. Obviously, you're not doing PSOs and VCRs and routinely in degenerative surgery, but you can do a lot of other posterior column work in conjunction with inner body work and compression distracted maneuvers to fine tune and affect segmental alignment through a single approach. So here's a case example of a 58-year-old female with neurogenic claudication secondary to multi-level lumbar stenosis spondy. Focus on the overall balance, particularly what's done to L3-4 in terms of alignment. She has an overall PIL mismatch of approximately 34 degrees, as well as 1 degree of kyphosis through L3-4. And she got a posterior 3-to-1 decompression fusion, and her neurogenic claudication got better, obviously. But look at what's done with the alignment. And this is a very obviously Dr. Coleman's case, because who else could get such excellent correction of the patient's global alignment? But you can see at the level where we chose to do an inner body, at the level of her worst stenosis, she got 15 degrees of segmental lordosis, and her overall mismatch is down to 15 degrees. And so she's pretty darn close to being in harmony there. There are, as great as the posterior approach sounds after this excellent talk, there are a number of cons. So, disc prep and alignment correction is a little bit more technically challenging through a posterior approach compared to a lateral or anterior approach. You're working through a much more narrow corridor. You're working around the nerve roots. You certainly you are at risk of a higher EBL, hospital stays, and infection, which is only really true if you do a lateral or anterior approach without doing any sort of posterior work. So this may not always sort of bear out depending on your patient and their needs. So in this study, they did a meta-analysis comparing outcomes of ALIF and TLIF and found longer hospital stays and equivalent infection with anterior and posterior approaches. But their studies included patients who got posterior work and instrumentation with an ALIF. So conventional wisdom might say that because TLIF disc prep is more technically challenging, they might have a lower arthrodesis rate, but this doesn't seem to be the case in the literature. And you can see several papers that sort of support this. So, as Dr. Coleman mentioned, adjacent segment disease might be a consideration in, whether or not you look at global alignment or segmental alignment when you do degenerative work. And so some authors have said that posterior-based approaches have a higher rate of radiographic ASD, but really, the ASD kind of happens when you have problems with segmental alignment. So in this study, they found the lowest rate of adjacent segment disease with ALIF, but that was also the technique that had the best segmental alignment compared to lateral or posterior approaches. So, again, just to sort of hit the same point again, is that, I'll sort of admit that a poorly done or mediocre ALIF or lateral is probably better than a poorly done TLIF. And sort of the take home point here is that if you fail to create and maintain good alignment, you'll probably break down at the adjacent levels faster than, it's probably not technique dependent. It's more probably alignment dependent. So to conclude the talk, the posterior approach is a classic, efficient approach that allows you to directly decompress the neural elements. You have the freedom to perform fascitectomies and PCOs to really get your alignment goals. And although it might be technically demanding, you can get them all from a posterior approach. At the end of the day, you have to pick the right approach for the right patient and pathology, and you really have to know the limitations of your approach. All right, thanks. So I'll sort of hand this off to my co-panelists here.
Yeah, let's have Evan give us his viewpoint on anterior column approaches that Sepin so effectively shot down.
I would be more than happy to. Thank you, Dr. Coleman. So I think it's great too that, are you guys seeing this? Let me get to the, sorry, 1 second. Are you seeing this in full view here?
Looks good.
All right, excellent. Excellent. So I like that. I really appreciate that Sapin ended his talk by saying that TLIF really wasn't a great option for correcting lordosis, and that lateral and ALIF were better, which was the conclusion ultimately of his talk, which I thought was fantastic. So thank you, Sapin. So that I guess decreases some of the burden of delivering what would otherwise be 2-hour-long talks combined into one 12-minute talk about anterior and laterals for maximizing segmental lordosis. So you got to talk, obviously we start, the goals of spine surgery: relieving pain, stabilizing a painful motion segment, decompressing nerve roots and relieving radicular pain, ultimately achieving a solid fusion and correcting deformity. These are the goals of the spine surgery. What I always had trouble figuring out, even during fellowship, and still sometimes now, is why do we use inner bodies? So inner bodies, if you want to achieve an indirect decompression of the foramen or centrally, if you want to relieve vertical foraminal stenosis, an inner body is really a great way. Otherwise, you're going to be distracting screws and kyphosing a patient. If you're not performing a posterolateral fusion and the inner body is your main fusion bed, or, and what we're going to talk about in this one, if you're restoring lordosis. If your goal is to restore lordosis, ALIF and lateral are really your best options. We'll start with lateral too, but I want to speak to something that Dr. Coleman mentioned too earlier when he started off, was if your goal, all of these approaches, you can achieve improvement in segmental and ultimately global lordosis or alignment, but you have to think about it. You have to have that in mind when you're going into the case. Is, the goal of this surgery is all the things that we mentioned in the last slide, but also we want to restore lordosis and improve sagittal alignment. That should be one of the goals or one of the thoughts whenever you're doing a short segment fusion. And so if you fail to think about that, you'll fail to address it, and you'll end up fusing people flat and then, sending them down the road of creating deformities, flat back syndrome, et cetera. So we'll talk to start with lateral, about the pros of lateral. So you're avoiding any neural element retraction, which is something you have in posterior. It's a minimally invasive, muscle sparing, except for the psoas, which has its own host of problems. There's no need for an approach surgeon. This can be done with a single surgeon approach. There's multiple levels accessible through a small single incision. You end up with a large implant footprint, which you can position in the disc space where you need it to achieve lordosis or improve foraminal height. And you have different cage parameters that will help you do that. High fusion rates with these, very low subsidence rates because you're spanning the apophyseal ring. But there are cons, obviously. There's anatomic considerations. And I think this is important in both the ALIF and lateral, is that you have, not all of these patients will be, not all of them will be eligible for a lateral or an ALIF, depending on their anatomy. So in the lateral, you have to look at the psoas. Do you have this Mickey Mouse sign or a high riding psoas, which drags the nerve forward and into your working corridor? So you have to be thinking about vessel and plexus location. You have to look at the great vessels in the front, make sure that they're not draping over, especially as you get lower in the spine at L4-5, where they might be starting to get lateral if there's a high bifurcation and could theoretically get into your working corridor. Do you have a high crest at L4-5? That would preclude you from getting to that level. Other cons that you have to think about are the thigh problems that happen after lateral surgery, and they are real. You can have postoperative quadriceps weakness, which is rare, and by and large, within 3 months, a femoral nerve palsy will improve. But you also have these dysesthesias or painful quadriceps afterwards, or whether it's damage to the genitofemoral nerve or the lateral femoral cutaneous. People will have these thigh symptoms that you have to take into account as when you're counseling them about these approaches. It does rely on indirect decompression. So the importance of getting an appropriately sized cage and not having it subside are particularly important in this approach, and also relies on specialized staff training and specialized instruments. But when they're done well, it achieves the goals of restoring sagittal balance and can do so really effectively. So here's a study, 144 patients at 2-year follow-up. They had less than 3 level lateral versus less than 3 level posterior lumbar interbody. And they found that with lateral, there was better segmental correction for 1 level fusions and significantly better improvement in lateral or lumbar lordosis and PIL mismatch for 3 level cases with lateral. There's another study showing the power of individual single level segmental improvement in segmental lordosis. So 61 levels, they had 40 patients. The only problem is that when you insert a 10-degree lordotic cage, you're not always going to get that amount of correction. In some cases you will, in others you won't. And so you can't count on getting 10 degrees from a 10-degree lordotic cage. And that's kind of par for the course whenever you're using an interbody, if you're not doing any posterior work, that you really won't get the full maximal cage parameters worth of lordosis from that cage. The other thing that they noticed in this paper is that there were reciprocal changes above. So there's ultimately no change in global lordosis, but groups did show between a parallel cage and a lordotic cage similar or significant increases in disc space and foraminal height. So these are some of the things to take into account when you're thinking about the morphology of the cage that you're using, is that you rarely will get the full degree or amount of lordosis from that cage height. If you do want to do that, then you have to start thinking about an anterior column release. So this is a cadaver study, biomechanical study, that compared lordotic cages with and without ACR. So you go down to this graph here at the bottom with a 10-degree cage at each level. There was maybe a a degree or two of improvement in segmental lordosis. When you added an ACR, anterior column release, you start to see much more significant improvements in your lordosis. And as you increase the cage height with the anterior column release, even further improving the amount of lordosis. So anterior column release is a really powerful tool to achieve lordosis if that's something you're doing. But the caveat is that it's an advanced technique, not to be used in all hands. Probably something that you would want to at least do a few labs and probably see someone do and have someone do with you before you were to embark on this on your own. Just more to the point on anterior column release and what kind of powerful correction you can get. And a lot of this is comes out of the MIS deformity literature. They started looking at how are we going to achieve improvement in sagittal balance through MIS techniques, and really started to look at anterior column release and what it can achieve. And you start getting in, you see approximately half of the cage angle when you're doing just an ACR. When you add an inferior facetectomy, so adding some posterior work, you start to see improvements in lordosis that approach the cage angle. And then when you do a complete facetectomy in the back, then you start to get to equal or greater to the cage angle. So the cage itself, in a well done lateral, will get you part of the way. But if you really need to improve sagittal balance with a lateral fusion, then you're looking at doing some bony work or an anterior column release. And these are advanced techniques that shouldn't be taken lightly. So in conclusion, the pros for lateral: high fusion, low subsidence rates. You can get good restoration lordosis, particularly if you are performing an anterior column release or posterior bony work, facetectomies or SPOs. It's largely muscle sparing. You can address multiple levels through a single approach. The cons are the thigh and psoas symptoms that we talked about, risk of visceral or vessel injury. The cage angle versus the actual expected lordosis can often be diametrically different from each other. And then you need to do these advanced techniques if you really want to maximize lordosis, which can be technically difficult. It's also limited by anatomy, patient's particular anatomy. It's not possible at L5-S1, and in some cases not possible at L4-5. So I'll switch over to ALIF, and we'll try and breeze through this as well. So the pros for ALIF: it's an easy discectomy. It's a built-in ACR. So you're taking down the ALL, you're taking out all of the disc, you have a nice wide working corridor to put in a really large cage, which will give you high fusion rates. So it's just placed from a larger space. And so you have a more powerful ability to increase that disc space on the apophyseal ring and achieve lordosis with less risk of subsidence. So it's just been shown that it's superior to TLIF in achieving foraminal height, segmental angle, and global lumbar lordosis for all of those reasons that I just mentioned. The cons, though, are that it usually requires an access surgeon. There are some guys out there that do their own approaches, but I think it's probably in this day and age most responsible to have someone there, a general surgeon or a vascular surgeon who is your approach surgeon, who can help with this approach. You're not really limited in the levels of exposure, but the more that you do, the greater morbidity you're conferring and the greater risk to injury to the great vessels. The iliolumbar vein is there. You end up denervating a fair amount of the abdominal wall if you're going up higher into the upper lumbar spine. So it's really, these are reserved by and large for L4-5 and 5-1, at least in this day and age, and for short segment fusions. And then there's a risk of incomplete indirect decompression when you put these cages in. And there's a need for potentially first stage posterior approaches or flipping the patient if you need to put in hardware in the back. All that being said, it's very powerful in achieving segmental lordosis and also improving global lumbar lordosis. A couple of papers here, and there are more out in the literature on the amount of segmental lordosis that you can achieve with an ALIF, and that often is reflected in global lumbar lordosis. So you're not really seeing the reciprocal changes that you do when you're doing a lateral that we talked about in a few slides ago, where you get segmental lordosis, but you lose the overall global balance. So here's a good example of that. Used a 15-degree cage at an L5-S1 ALIF for a patient who was having an L5 radiculopathy for foraminal stenosis. Got excellent improvement in their segmental lordosis and their overall global lordosis, and basically eliminated the PIL mismatch. And so they're setting them up for success long-term, not having to, hyperlordose through the 4 or 5 segment, wearing it out faster, have a good balance here that hopefully will be long lasting for them. I think Dr. Coleman will probably end up getting into this. Some of the new technology, hyperlordotic cages, they may or may not work. I think the jury's still out there. Depends on how you're using them. For an ALIF cage, there was a paper, 41 patients with hyperlordotic cages, 30-degree ALIF cages. In this paper, they did an SPO if the end plate distraction wasn't parallel, and they did this at 29 levels. And the hyperlordotic cage provides excellent segmental lordosis, but you can sometimes end up with problems with edge loading or creating foraminal stenosis. You're putting these hyperlordotic cages in, or these expandable cages, which is what actually Dr. Coleman might be talking about. So you have to weigh the risks and benefits of a hyperlordotic cage, and make sure that if you are putting it in, you might have to do some posterior bony work to make sure that you're not just loading the edge of the vertebral bodies where you place this cage. So in conclusion, high fusion rates with ALIF, you can place a large footprint cage and you've got a built-in anterior column release, giving you the best chance at improving your sagittal parameters. It's versatile. There's less disruption in the posterior soft tissue, even if you do go back there to put in perk screws or do a formal decompression. The cons are that there are obviously limitations associated with the anterior approach in terms of how many levels you can do, and the morbidity and potential risks of that, needing an approach surgeon as well. And then there's the perils of the hyperlordotic cage that we looked at. So in summary, I think ALIF and lateral are the best options for restoring segmental lordosis. I think that's fairly obvious. Releasing the anterior longitudinal ligament is going to be the best way to maximize lordosis and make sure that you're maximizing the cage angle and segmental lordosis, and adding posterior column osteotomies makes it even more powerful, but those are advanced techniques. There's unique complications and risks associated with these two approaches, and it's really important to study the anatomy, because not everyone is going to be eligible for this. And in those cases, a posterior approach would work fine, as Sapin showed us. So you have to consider the risks and benefits of your cage and cage morphology, and always keep in mind the goals of the surgery. If you need lordosis, you really need lordosis as a major factor in the surgery that you're performing, anterior and lateral should be the first thing on your mind. And if you're just trying to achieve foraminal height, parameters are otherwise okay, then I think a TLIF would work just fine in that scenario. So thank you guys. I think I'll turn it back over to Dr. Coleman now.
Thanks to both of you. There you go. So I just want to comment that I thought both of those presentations were great. I thought you presented great data on sort of what the success stories are out there with each technique. But what comes to mind to me, and the problem I've always had with all these comparative studies is, there's a spectrum of technique even within each of these techniques, right? So not every TLIF is the same, not every lateral is the same. It really depends. Even hyperlordotic ALIF, they're not all the same. It depends on what you do in the back and how you compress the screws and what kind of osteotomies you do and how mobile the spine is, how degenerative the facets are. So there's just so much variability. And I guess one of the things I want people to come out of this webinar with is not necessarily a clear answer, but an application of consideration for your actual, the fine tuning of your actual T-lift technique, your lateral technique, your A-lift technique. I think there's surgeons out there that believe in one technique. I tend not to be. I use all of these techniques, and as I do more of them, I've tried to think more and more about what's the best way to manipulate the spine using this technique, and what am I not doing, and all those kind of questions for yourself. So I think just realize there is no right answer. There's a spectrum of technique. So try to do a good job. I don't have too much on emerging technologies. I actually am way beyond even the expandables and cage designs, the widget designs there, Evan. Thank you for foreshadowing this. But yeah, I had a couple other things to talk about. I don't want to spend too much time on any one technique, but I wanted to show a couple things that people are interested in, which help us achieve lordosis. So doing a lateral surgery in the prone position is one thing that potentially is a best of both worlds. So you get all the power of the lateral approach, but you also have simultaneous access to the posterior column, so you can do a direct decompression and compress osteotomies and compression off the cage, et cetera, et cetera. So that's kind of a technique you could give a whole talk on, but I wanted to just highlight it as kind of an emerging direction that really I do think is powerful in this arena. And what about navigation? So, navigation right now allows us to put in pedicle screws very accurately. But the future of navigation might be to put in pedicle screws accurately that are sort of in a very specific directionality. And maybe you'll see a return to uniaxial screws, where if the pedicle screw is just placed perfectly in a converging or diverging angle, when you put a stiff rod into that pedicle screw and force the spine to the rod, especially if the screw is a uniaxial screw, maybe that achieves a different segmental lordosis. And obviously that's totally dependent on perfect, accurate placement of the screw, which is what navigation lets you do. So also, can we consider how to navigate the position of our inner body? Most of my T-lifts, I've gotten pretty good at doing a cantilever T-lift and putting a banana T-lift up in the anterior column, but it's still a little bit of an unknown. You never quite know precisely where it's going to end up, despite using a lot of fluoro. So maybe navigation allows us to put our implant in the exact pre-op planning place that we intended to, and that helps us achieve more lordosis. So kind of some more abstract technique thoughts, but I wanted to pique your interest. And then augmented reality, we've talked about augmented reality. People are interested in augmented reality, but all augmented reality does is let you overlay digital information on top of your surgical field. So what if new technology in segmental correction is about more than just placing instrumentation particularly, but actually to see through your headset, no, this segment, maybe you could look at the side of the spine and say, no, this segment is not quite yet at my pre-op plan. I need to build in more lordosis, et cetera, et cetera. So just more digital overlay information. And I think in general, one of the important things in deformity, and I think should be in degenerative, is that intraoperative assessment of how we've done is pretty poor in today's age. So, there's a bunch of different technologies that allow for intraoperative assessment, but I don't think any of it's really caught on very well because it's not very user friendly. It's sort of displayed on a screen somewhere in the OR or on a computer. And so what if in your visual field, you can start to really understand how well you're correcting alignment intraoperatively. So that's where I see that going with augmented reality. And then I have to put in the requisite robot slide in any technology section, but one interesting thought is if we can put pedicle screws in spinal segments and we can loosen the spine, maybe a robot becomes our new manipulator. Maybe the robots are our rod bender, our reducer, our compressor, our distractor. Maybe robotic arms attach to screws and sort of affect segmental change automatically in a precise way. So that's just to pique your interest. I wanted to finish up before I want to have a couple minutes for discussion, but just to finish the case we presented in the beginning of the talk, we had this grade 2 degen spondy. I didn't present any pelvic parameters intentionally because I think a lot of people just look at this case and say, oh, we need a posterior lateral fusion, or we need a TLIF, or we need, whatever, if you think you can get a right-sided lateral potentially. But when you add in the pelvic parameters, you realize that the segmental lordosis at 4.5 is less than a degree. You can see that L4 is still kyphotic. It's not level to the floor. You really don't, 2/3 of lumbar lordosis should come 4:1, and you really don't have much lordosis 4:1. You have a pretty good, maybe I was probably a little generous with the lumbar lordosis, and you probably have even more mismatch than it looks like, probably more like 20 degrees. So I think this is a great case. It looks like a simple case, but it's a great case to build in lordosis, to really go for lordosis. And we know you're probably not going to get 20, 30 degrees out of a interdiscal manipulation, but if you get as much as you can, I think you'll be doing this patient a service. So what I did was a cantilever TLIF, where we put the TLIF, banana TLIF, way up front, and I do like a partial posterior column osteotomy. So I do a facetectomy on one side, and then I really drill out the contralateral facet and make sure it's loose. And I also do a partial osteotomy of the anterior, or the distal, maybe 30% or 40% of the facet, just to loosen it further. And then I really compress bilaterally on these rods and try to crank the spine into lordosis. So I don't worry, like the hyperlordotic ALIF, I don't worry about closing the foramen because I've got something to rock off of. That cage is never going to let the foramen collapse, and I can see the roots directly. So I'm not crowning Sapin the winner here of the debate, but this is what I did in this case. I think it's a nice case that illustrates our examples. So I would like to, I was wondering if Dr. Gandhi and Dr. Shia can sort of unmute, and we could do just a little discussion. I wanted to start by just having a mini debate, and I want to pose a true or false question. So, to my esteemed faculty, true or false, it doesn't really matter what kind of anterior column device you use, as long as you are aggressive in the posterior spine with osteotomies and compression. True or false?
You want to go first, Evan?
Yeah, I'll go first. So I think it always matters the cage that you use. I think I showed that in my talk, and I think the main thing actually about the cages, especially when it comes to like a TLIF or a lateral, is the cage placement in the vertebral, in that space. It has to be in the anterior third. I think you really showed that well in that last case, Dr. Coleman, that if you have the and this has been borne out in the literature as well, if you have it at the front third of the disc space, you can actually achieve lordosis through a TLIF. Like that, placing the cage appropriately is one of the keys. So I think that the most important part of a good inner body, whether it's a TLIF or a lateral or an ALIF, is the cage placement. And I think that the cage morphology itself does play a factor, but really cage placement, good disc prep, that's going to be the major thing. But certainly, like if it's stiff, then you'll have to go in the back and do those PCOs, and then the rest of that literature from the laterals shows what kind of power you get when you actually do the bony work in the back. So if you need it and you planned it out that way, then you should anticipate having to do some more bony work in the back. But a well done, well-placed cage in the front with a good disc prep should get you what you need, regardless of approach.
Got it. So you're saying for most cases, the cage is the powerful part of the technique, and you don't need to go and do osteotomies. I
You
think,
disagree?
well, I don't know. I think I agree for a lot of cases. I think maybe I could rephrase your thought and highlight what you said about being prepared. You know, a lot of times you'll put that lordotic cage in, or you'll think you did enough of a release, and it's sort of edge loading, and it doesn't look great. And I think you got to be prepared to fix that with a posterior osteotomy or compression. It's not a very, I mean, these osteotomies do not have to be very morbid. You know, I mean, they're really pretty straightforward once you do them. So I sort of think the posterior osteotomies should be done more often than they probably are. But I appreciate your point that for most cases it'll be okay, but you should be ready to, you should at least think about it.
Yeah, absolutely. I mean, it should be part of your plan. Like if you're looking at that person's spine, I think you mentioned it earlier too, them standing versus supine, like you're going to get a sense from a standing film to a CT or a lumbar MRI, what kind of mobility is you can expect when you get them on the table and relax them. So like you should know going in whether or not, with like a high degree of certainty, like I'm going to be doing some posterior releases here because this is not a flexible segment. I'm not going to be able to do it without taking out some bone in the back. So I think that's something you should really know going in, and certainly be prepared to do. If you by happy accident find that, yeah, it's, it actually worked out, I just did the inner body and like that was enough, and I got the intended correction, that's great. But you probably know that going in based on the flexibility of the spine.
I do think the probably the actual device, just to go back to your original question, is probably not as important as what happens with the posterior work, particularly in the posterior approaches. So like, I think you can make somebody with a hyperlordotic cage or an expandable cage, you can make them completely flat with a T-lift, or you can make them have a nice like 10 or 12 degrees of lordosis, depending on what you do with the facets or the screws and rods. I actually think you have a little bit less control over what happens, and this may be just my experience with laterals and anteriors. You have a little bit less control over what happens with that alignment from the front and side. It's really dependent on the cage and the disc prep, and like maybe the actual cage that you use. And oftentimes like you just kind of like jam something in there that doesn't matter if it's 10 degrees, 12 degrees, 15 degrees. The disc space just kind of does what it wants once you like prep it, because you haven't done anything in the back to kind of change the alignment. So from a debate standpoint, like, yeah, I think that, and I said this kind of in the talk, is like a mediocre lateral and anterior is probably better than a mediocre T-lift. And part of it is the amount of like control you have. And if you don't pay attention to it from the back, you can kind of screw things up. Whereas like it's harder to screw things up with a lateral and anterior.
Yeah, great, all great points. We had a good question in the Q&A from Dr. Butler, one of our current fellows, about if deformity concepts are so important, do we think that you need full-length films on everybody? And Dr. Shia, do you want to? We both responded, but do you want to comment on that out loud, just for the panel, for the?
Yeah, I always get full-length films just because it's easy. That part of that is just like an office workflow thing. But then I have everything there. And I mean, they really stress it at HSS. It's always a topic of conversation, is your sagittal balance. We think about it for every case. Like it's very much, I don't know if that's a Hanjo Kim thing, but it's like a very much a stressed part of the treatment of the patient. And I think if you have the standing Scoli films right away, you can assess all the parameters, and you have all of that available versus, it kind of cut off at 12 and looks like maybe there's like a little starting to get into some like thoracolumbar kyphosis. I don't see it. So then you send them for Scoliosis films afterwards. Like you have to have the full length picture to make a statement about sagittal balance. And also the other thing is just logistically, when you're getting just lumbar films, oftentimes those don't include the hips. So oftentimes you won't be able to measure your pelvic parameters, at least the way that we get them. Maybe if you specify that with your radiology tech, but that's
right.
just,
I was going to make the point that for me, a lot of these degen cases, really the only thing the full length film tells me is, wow, I really missed the boat, and this is actually a T10 to pelvis or T4 to pelvis kind of correction. I find it rare that as long as I see the hips on the lumbar film, and I can assess, listen, the whole workflow and the process of pelvic parameters and incidence and lumbar lordosis is everybody's sacrum is sat in their pelvis in a different way. And if your sacrum is fixed relatively horizontal, you need a lot of lumbar lordosis coming out of it, and vice versa if it's fixed very vertical. So for me, looking at the incidence and the pelvic tilt and the sacral slope and the lumbar lordosis, for me, that kind of gets me most of the way there for most cases. If I have a clinical sense that the patient's globally imbalanced or very compensated, like high levels of flat upper back and a very hyperlordotic neck, for example, if I get that sense, then I'll get full films. But at Rush, we have a lot of patients to care for, so we can't just get EOS on every single patient, Dr. Shia, unfortunately.
Well, yeah, I don't have an EOS, but I just get a regular Scoliosis films. But I think some people would also make a case for like getting some guys get full length standing, like full spine and hip to ankle to appropriately assess global sagittal balance. And I think that's like the next step.
Yeah.
But you make the case if there are hip flexion contractures, like you see just a lumbar spine film, you don't get any sense of what that person's alignment is in the world. So,
yep, agree. And then just one other question. Dr. Wu had posed the question. So it's great. ALIF and laterals can give you all this lordosis in the segment, and they're great in comparison to TLIF. But why aren't we seeing that translate into patient outcomes? Sepan, do you have any comment on that?
Yeah, I think it really goes back to the point of what we were talking about before. Really, this conversation's coming up because we're starting to track these patients for a longer period of time. We're looking at what happens to them 5, 10, 15 years down the road. And really we're starting to see that, like, being thoughtful about segmental alignment may help decrease adjacent segment issues, or may help decrease rates of like bigger deformities that may require more intervention. And I think it's very common when we're looking at things from a research standpoint to follow patients for a year or two and then say, oh, well, they did fine, and like sort of ignore what happens to them like further down the road. So, we may be in the short term, like, Shiha might do a standalone ALIF and I might do a TLIF, just probably wouldn't, but like, in that short period of time where we follow our patients for a year or two, both of our patients may do well, but he got better alignment than me. And so now I'm going back for 4 or 5, like after I stop following this patient in a research study. So I think that, like really like following patients over a really long period of time to look at things like adjacent segment disease or operation at adjacent levels, that might bear out, compared to like a shorter term study that just looks at the 6-month post-operative X-ray and says ALIF is better, but like they're both doing well, so
it's like the resolution of what you're measuring and what you're paying attention to is probably the explanation. As we get more sophisticated, we'll we'll see that more and more. And Sepin or Evan, just one last question from Dr. Savage. It makes a great point, which is, how do we think about cost? Do I really need an expensive expandable implant and a robot to move the spine around, or can I do the same thing with a peak cage? And is there, this goes back to value equation, right? So what's the actual outcome benefit? We've argued about that a lot, but if we don't pay attention to costs and we don't really know what the value is, there's very expensive things that have better outcomes, but might not be worth it. So what are your guys' thoughts about the cost?
Yeah, this is like the story of orthopedics, right? You do it and then you do it for a long time and then you study it afterwards to see if like the cost was worth it. But definitely it's a value equation. Like if you can make the case that using this fancy thing does have a cost saving ultimately, then I think you can justify its use. Otherwise, if you're just you have like a single segment degen case, it doesn't need major restoration of sagittal balance globally or segmentally, and you just need to fuse a spondy, you definitely can do a standard posterolateral fusion. It's been done for years and years and years, and there's been no issues with that. But when you're getting into like fancy cages, things like that, other technologies, we have to be studying these and making a case for why it makes sense, and backing that up with good research.
Go ahead.
Oh, sorry. I was going to say that I certainly think in our field, in spine surgery in general, like different patients are different. It's not just a patient with hip arthritis that needs a hip replacement. Like, there are patients that require like a more aggressive correction. And, some of the studies that we see that lump a lot of people with like a 1-level degen spondy into a similar category, look, there are nuances there. And so it's going to be hard, I think, to sort this thing out moving forward about like, how are we going to sort of sort out who needs an expensive surgery with fancy implants and who does not. I think that's going to be an ongoing question. It's not really like a great answer to Dr. Savage's question, but it's just pointing a light at the issue, so to speak.
I'm gonna adjourn us because we're a little bit over our hour, but I want to thank all the panels. Just the last question that I actually think is important. With cantilever TLIF and a PCO, what's the maximum amount of lordosis we can get? Like how should, we think about, pedicle subtraction osteotomy gets us 30 to 40 degrees if it's very aggressive. What can this do? How should I think about this? And I would just submit that it's very technique dependent. And I was laughing to myself because I made a golf analogy. I hit my 9-iron 150 or 155 degrees. Someone like Dr. Savage might hit his like 110. So I hope he's still on the call. And furthermore, I might not hit my 9-iron 155 degrees in wet conditions or in wind, right? So you have to understand the spine you're operating on, and you have to know. I would suggest that you start paying attention to how much really critically evaluate your postoperative x-rays when you've tried to do this technique, and you'll dial in sort of what your capabilities are in different settings. So that would be my comment. But I want to really thank Dr. Shia and Dr. Gandhi for taking the time on a weeknight to do this with me, and thanks for everybody that tuned in. Looking forward to seeing you at in-person meetings, Fellows Forum, and future webinars. Thank you very much.